Dr. John Cangemi. Dr. Cangemi is Associate Professor of Medicine in the Division of Gastroenterology at Mayo Clinic, Florida. He'll be giving us 2 talks today on GERD as well as on inflammatory bowel disease. Dr. Cangemi.
Okay, we'll start out with a case study. This is something you'll see commonly in your office. A 54-year-old Caucasian male, 10-year history of classic heartburn, at least 2 or 3 episodes a week, both postprandial and at nighttime. Occasionally it will wake him from sleep. And he has intermittent regurgitation and maybe some general fatigue and some poor sleep pattern. And he has mild postprandial bloating. He tries self-managing. He usually takes some over-the-counter antacids, and it may give him temporary relief, and H2 blockers may work a little bit better. But his primary care doc described lansoprazole, and health plan wouldn't pay for it, common problem with these expensive drugs. So he's using over-the-counter omeprazole on a semi-regular basis, and he's referred to you because his local doctor wants him to undergo endoscopy. So we're going to basically start with that case, and we're going to talk a little bit about the mechanism of action or mechanism of causes of the reflux syndrome, how common is it, and also we're going to talk at the end about treatment and specifically how do we test for it. So we all see it. It's the most frequent complaint of GI symptoms that come to our office in the GI clinic, and 20% of the Western world will complain of reflux. The problem is 1/3 of them don't have reflux, so they're complaining of it, but they've got something else going on. And in reality, the symptoms have really a very low specificity and sensitivity for actually telling us which patients are true refluxers and which aren't. But the cost is phenomenal. $9 to $10 billion a year is spent on GERD management, and mainly because of the drugs. It's the PPIs, which are outrageously expensive. Even now, in the over-the-counter form, they're better. So why do people reflux? Well, you have an anti-reflux barrier, and that's got basically 3 components. The lower esophageal sphincter is probably the most significant component, but you also have benefit from the hiatal hernia, from the diaphragmatic hiatus. So if they have a hiatal hernia, there's an increased predisposition. And there's something called the esophageal flap valve, which is actually comprised of one of the phrenoesophageal ligaments, and also there's some circular muscles in the top of the cardia of the stomach called the sling muscles, which also help support the reflux or help prevent reflux. But reflux is actually physiologic. We all reflux to some degree after a meal. But what's different is the duration and the intensity of the reflux that distinguishes those who get symptoms and those that don't. And we do have some natural defenses against reflux that help to limit and make these very short-lived. And that's actually saliva. Saliva is a great way to neutralize acid reflux because it contains largely bicarbonate. And the other thing about saliva that's interesting is it also contains something called epidermal